Hello everyone, and welcome to a new episode of Ask Stago, the podcast from Stago. This platform is dedicated to answer the questions that you may have about our products or hemostasis in general. My name is Lisa Gannon and I'm a product line manager here at Stago, and I'm really glad to be the new co-host of this season. To animate today's session, I'm joined by Audrey Carlo, Scientific Marketing Manager. Hello Audrey.
Hello Lisa, that's so nice to have you here with me.
So Audrey, what's the subject of our podcast today?
We will discuss about the connection between women's health and coagulation. As you know, bleeding and clotting disorders affect both men and women, but these conditions pose unique problems for women because of the impact the disorders can have on their reproductive health and quality of life.
Yes, Audrey. In fact, the current CDC data estimates that as many as 1% of women in the United States alone may have a bleeding disorder. And many of those are, in fact, unaware of their condition. Clearly, a timely diagnosis and robust patient management has a key role to play. To elaborate further on this topic, we are delighted to have a special guest, Dr. Francois Depasse. Hello, Francois.
Hello.
So, Francois, you are our Clinical Development Director at Stago and the most knowledgeable on this subject. Thanks for accepting to kick off our Ask Stago Season 4. So let's start with our first question. Francois, can you tell us about the most common coagulation disorders which are impacting the reproductive health and quality of life of women?
Yes, sure. The most common observed disorders impacting female reproductive health and quality of life includes, for what regards coagulation disorders, women living with von Willebrand disease, antiphospholipid syndrome, hemophilia in some very rare cases, or more frequently hemophilia carriers, platelet disorders, and other rare bleeding disorders.
And Francois, can you tell us more about the impact of von Willebrand disease or lupus?
Yes, the most common bleeding disorder affecting women is von Willebrand disease. Also, von Willebrand disease occurs in men and women equally. Women are more likely to notice the symptoms of non-severe forms of the disease because of heavy or abnormal bleeding during their menstrual periods or after childbirth. Von Willebrand disease and other blood disorders may also cause women to experience recurrent fetal loss, heavy bleeding during dental procedures, frequent nosebleeds, and heavy bleeding during or after surgery.
And what about APS?
So, antiphospholipid syndrome is an autoimmune disease in which antiphospholipid antibodies, for example, lupus anticoagulant, react against proteins that bind to anionic phospholipids on plasma membranes. Like many autoimmune diseases, it is more common in women than in men. The clinical events leading to lab investigation for antiphospholipid antibodies are thrombosis and vascular diseases, one of them being pregnancy losses.
And actually, we covered a bit the Sapporo criteria leading to APS diagnosis in one of our past episodes in Season 1. This was clear that one fetal loss is, I should say, sadly not enough to lead to APS diagnosis. That is recurrent miscarriage, the entrance point.
This is true, and definitely one has to know that for a pregnant person affected by APS, there is an increased risk of recurrent miscarriage, intrauterine growth restriction, and preterm birth.
And so if we focus on APS, can you tell us how we can approach the lab diagnosis?
Well, as you said earlier, the classification criteria for APS were formulated during the Consensus Conference in Sapporo and revised in Sydney in 2006. APS was then defined as both clinical and biological syndrome. To achieve the full APS diagnosis, you have to confirm at least one clinical manifestation and one laboratory marker. Lupus anticoagulant is one of the biological markers.
And Francois, if we move on to the laboratory parameters investigated for APS diagnosis, what should be the lab tests?
So the lab should test for lupus anticoagulant and for the presence of antiphospholipid antibodies, namely anticardiolipin and anti-beta-2-GP1. The number of positive laboratory criteria, single, double, or triple positivity, helps to further stratify the APS, and it is recognized that patients who are positive for all three criteria, so-called triple positive, are at high risk of thrombosis and recurrence.
And as the lab results may be transiently positive due to acute phase after a thrombosis or some drugs treatment, the tests panel should be repeated twice, 12 weeks apart.
And Francois, what about lupus anticoagulant testing itself? What are some of the challenges we can face when assessing for its presence?
So there are several guidelines available worldwide to describe the diagnosis of lupus anticoagulant. To quote the two main ones, we have, for example, the CLSI guideline H60A and the ISTH guideline updated in 2020 by Catherine De Vries and co-authors. Of course, all guidances are valid, but perhaps the ISTH guideline is more simple to follow whilst remaining fully comprehensive in a clinical laboratory context.
And Francois, in this latest ISTH guidelines, what have been the main updates?
Well, first of all, like all guidelines, the main message is consistent and clear in that they recommend the use of two independent pathways in the determination of lupus anticoagulant, a sensitive APTT and a DRVVT pathway incorporating a screen, confirmatory, and mixing step for each pathway. The new guideline has simply added further details on the order of testing for further enhance the sensitivity of the test. The use of the mixing study in parallel to the confirm test in the case of a positive screen for both the DRVV pathway and the APTT is mentioned. There is also the option to perform a mixing test on both confirmatory samples to enable better interpretation of the results, for example, in the presence of anticoagulation or factor deficiencies.
And Francois, one last question for the conclusion. What are the main challenges or barriers we face when seeking an APS diagnosis?
The key one is clinician know-how and the confidence on when to seek further APS investigation in the presence of clinical symptoms. The trend has been to wait until the third miscarriage, and the American College of Obstetricians and Gynecologists states that no workup is generally recommended until after the second consecutive clinical early pregnancy loss. This is because approximately 50% of early pregnancy loss are due to fetal chromosomal abnormalities, and because the most common risk factors identified among women who have experienced early pregnancy loss are advanced maternal age and a prior early pregnancy loss. We can, however, imagine the great psychological and physical trauma and risk to the patient, not to mention the overall burden on the health system caused by these pregnancy losses. This may explain why we are seeing more and more clinicians requesting APS lupus workups before that stage. Then there are, of course, also the practical considerations, for example, testing outside the pregnancy and anticoagulation, and hopefully the new guidelines are helping to clarify this topic more and more for the wider scientific community.
Thanks a lot, Francois, for sharing your knowledge with us today. That's very impressive, and we need to think more about this impact of laboratory workup on the health system. This is a very interesting topic, and there is still so much to discuss, I think, on this burden of thrombosis and hemostasis issues in women.
And yes, we have come to the end of this episode, and thank you all for listening. As usual, all literature sources and links to the previous podcasts are listed in the podcast description. Please feel free to send us any questions that you may have at our email address, ask@stago.com, and we'll be glad to answer it in the next episode. To be aware of the next episode, please click on the subscription button. It's free, or follow us on Twitter and LinkedIn. See you next time.
This podcast is brought to you by Stago. Diagnostics is in our blood.